So let's, with your history in sports medicine, your history in sports in general, let's talk about that kind of athletic population. I know that I'm seeing, 40-year-olds to 60-year-olds that have been highly athletic. I always share this story. So until recently, I've been going to CrossFit. I've done CrossFit for 6 or 7 years. Within my CrossFit class, it's a mixed class. I've had at least two people that have had total knee replacements, one bilateral, one unilateral. I've had an individual in his 70s with a total shoulder replacement. And so I see this population now. They weren't my patients, and we just know each other socially, but it's just so fascinating to me to see what they're doing. And of course they want to jump rope and they want to jog and they want to do these things. So I know you've seen some of my content that I've put out where I said, we can't really give a one size fits all answer. But from your perspective, in terms of seeing these, I'm going to make it a little bit easier to give you kind of an example. Let's say the
Sure.
individual who's within reason, kind of normal weight, has been active. I just saw a post in my group 2 days ago. This individual had been running 15 miles a week. She can't run more than 15 miles a week or else she pays the price. But, body weight is on average. She's been a runner her whole life. She's got a deep history of athletics. And she's going to have a knee replacement. She
Okay.
wants to be able to return to some of these activities. How do you find kind of the recommendations and the advice for these individuals?
Sure. And the main issue is that when these were first conceived, joint replacements never were designed
Right,
initially or built for running, right? It was
right.
built for walking. And yes, there are, while you can argue that yes, the load of walking a mile versus running a mile total ends up being about the same because you've covered the distance with the weight.
Sure.
It's sometimes it's the amount of the rate of loading. So we talk about
Yeah, the
how
the
quickly
peak
that joint
impact,
is,
right?
right, that peak impact. So there are some trends also in implants that can help us solve this problem a little bit more, other than the fact that they've just become more durable. So if you look at what we call a cemented implant, so those are put in and they're actually glued to the bone at the time of surgery with a fast setting that cement that sets within about 15 minutes of when we mix it. And the issue with that is that's as hard as it's going to be at the instant that it sets up. That's as good as it ever gets as far as its bond to your body. So if you're pounding on that repetitively over time, there's, certainly you're thinking, well, yes, you're going to increase the chances of that cement breaking down, something becoming loose, and then needing another surgery, which, as I always tell patients, the second surgery is never as good as the first.
Right.
Diminishing returns with joint replacement. And initially we told our young patients, we stayed away from surgery because we were afraid that by the time they were 70, we're just going to run out of bone to be able to attach things to.
Sure.
So you look at the cemented knee replacement population, certainly there are some that are able to run on those, but it's not highly recommended. Now we have started developing more, and it goes in phases because we've had cementless knee replacements for a while, had various types. With the advent of 3D printing, we've made them a little bit better. So
Wow.
we have right now one on market that is made by Stryker. We actually can put it in with robotic arm assistance to improve the accuracy of its fit, and it's a press fit knee. So if you think about the bone sort of growing into the implant, that bone will then over time form a firm attachment to the metal. That is a biologic attachment. So similar to what we do in our hip replacement world, pretty much all of my hip replacements are in growth, we say, or cementless implants. And that allows the bone to change over time with stress. The bone responds to where stress is. So if you're talking about running after a knee replacement, I probably feel more comfortable telling a patient that wanted to run that they should have a cementless knee replacement versus a cemented one. I think that they can both be done, and I've certainly had patients do it. And certainly I've got a patient who did a hip on that does the Galloway run walk program on marathon. So
Okay.
didn't tell him he should, but I've long ago figured out the patients don't always listen to exactly what I tell them. They're going to do what they feel is healthy for them and what they're going to
Sure.
be able to get through. And if it's not hurting them, who am I to judge necessarily, other than tell them yes, there's risks, and certainly if you fall down and break something, that's probably the biggest thing.
Right.
So, so with the cementless knee replacement, though, we have to say what are the pluses and minuses between cemented and cementless knees. Well, if you take a look at the knees done in the United States as far as knee replacement, probably virtually 85 to 90% are cemented.
Okay.
And that's because they have a low early failure rate um, versus the cementless. Because again, the cementless relies on the body to grow bone into some pores in the metal that
Right.
then attach, right? So if that bone ingrowth just doesn't happen, then you're stuck with a painful knee that just doesn't improve, doesn't heal, and you have to go back in and cement a knee in. So if you look at what we call registry data, so they take total knees done from all various places in the country and by different surgeons, and you look at registry data on cementless knees versus cemented. At the 2-year mark, up to 2% of cementless knees will be revised because of pain and failure to ingrow. Now, means you got a 98% shot you're going to hit it out of the park.
Sure.
But if you take a look at cemented knees, 0% went
Wow.
back through another surgery in that 2 years. So you take a young patient in their 48, 52 category, and you put them through a cementless knee, and they're working. They've got a job. They've got to take their time off, take their short-term disability or whatever, or just save up enough money to be off because they're a sole proprietor. And then they go through the recovery. They get a little bit better, but they don't get all the way better. And then in a
Right.
year or so, they're looking at coming back through another major surgery. That's a pretty big financial hit. So
Yeah.
you always, like I said, there's lots of pluses and minuses to weigh when you look at these things. Now, if running is very important to you, you might say, well, all right, so technology is catching up. Ingrowth type prosthesis is probably better for me to run on long term than a cemented one. Then you say, all right, well, it's worth that small risk of it not growing in and me needing to have an early surgery versus the risk of this going on for maybe 5-10 years and then I wear it out twice as fast as I should have
Right.
from a cemented side. Because I think that then you gotta take away from the discussion is what's really important to you in life, right?
Yeah.
So if it's my job and being able to walk and work, and the other side I would say is on cementless knees, on average, patients probably take somewhere around 2 to 4 weeks longer to feel better because of that ingrowth, right? That ingrowth
Right.
has to happen before it feels sturdy and stable to them. So they have a little bit more pain early on. They probably take a couple weeks longer to meet their goals when it comes to function compared to a cemented knee. But then maybe you're getting a little bit better longevity,
Right.
especially with impact activities. So, there's, again, pluses and minuses. So my job as a doc is to say, these are your risks. These are your benefits. This is what I can do for you. What do you think? And it's called shared decision making. We've had that in medicine for a while.
We've
And
had it, but I don't know how many patients would believe they, have a surgeon who will do it,
sure,
truthfully. And I'm sure you hear these stories. I mean, and that's what's one of those unique things about you personally is just that I know you do take the time. I know you do look at the big picture and you take other aspects of the individual's life into account and you have these conversations. And that goes back to what you said 20 minutes ago when you were talking about, treating the whole person and wanting to understand and having the time to
yeah,
actually talk to that individual and get to know them. Certainly that's the benefit we have in therapy is we have hours and hours and hours of time to get to know an
yes,
individual and understand the fears and the anxieties and all the other stuff that goes into pain. I mean,
sure,
pain is such a huge factor here outside of function.
right. Right. It's pain is what's bringing them in. Because, seldom do I see a patient come in with knee arthritis and say, it's all about my function. It's the pain that brought them.
Right.
Then it's the conversation that says, well, what aren't you doing now? So,
Right.
sometimes there is some, function loss brought up, but most patients are coming in saying it's pain and this is stopping me from doing what I want to do.